Good afternoon. Today we are going to discuss MRI in rectal cancer. Today we are going to highlight the MRI anatomical background for the rectum, MRI protocol, what does the clinical oncologist and surgeons want to know before concurrent chemo and radiotherapy, and how to assess treatment response, and also we will highlight some recent imaging tools. First, we are going to discuss the rectal anatomy. The rectum is about 15 centimeter. Its lower limit is at the level of the anorectal junction, which is the insertion of the levator ani muscle. Here we can see, as our dear professor Dr. Rania mentioned, this is the puborectalis muscle, and this is the upper limit of the anorectal junction. The upper limit of the rectum is at the rectosigmoid junction, and it is mostly opposite the sacral promontory. We can identify the upper portion of the rectum opposite the sacral promontory over here, or the S1 vertebra. This is the upper limit of the rectum and the start of the rectosigmoid colon. And it is very important to highlight the location of the rectum, the segmentation of the rectum, to identify its upper and lower limit, to identify the exact location of the tumor later on, as we were going to discuss. MRI identify the mesorectum, which is the fat content surrounding the rectum, and it is limited from outside by mesorectal fascia, and it appears as a low signal intensity structure surrounding the rectum, as we can see over here. The mesorectum is mainly containing fat with few lymph nodes and small vessels with small fibrous septa. MRI is important to identify is it is a tumor or not, and if it is a tumor, then where is the tumor located and what is the proper staging. These are the questions we are going to fulfill in our report. So, can we ask for CT or MRI or PET-CT for evaluation of rectal cancer? MRI is the best choice for local staging for rectal tumors, but CT and PET-CT are preserved for staging for the abdomen and distant staging, including the chest, if there is any clinical suspicion for distant metastatic lesions. Why MRI is best imaging tool for assessing the rectum? Because we can precisely evaluate the location of the tumor, and also it is very important to assess the TNM staging, and it is helpful in evaluation of the mesorectal fascial assessment, which is very important for the surgeon to identify if there is a violation of the circumferential resection margin or not, and also because we can precisely evaluate the anal sphincter complex to allow the surgeon to prepare for sphincter sparing surgery if we are dealing with a low rectal tumor. So how can we perform this MRI? We usually use a high field machine, either 1.5 or 3T. Usually 1.5 machine is very good for evaluation of the rectal tumors. We start with the sagittal T2 weighted image, and then we are going to take the axial and the coronal T2 weighted images, and these are actually the money images for staging of rectal cancer. Sometimes we can add some functional imaging, including diffusion and ADC, and not routinely use the DCE images, which could be also used, but mainly for research purposes rather than for clinical evaluation. So if we are performing rectal cancer protocol staging, we can just be limited to the anatomical imaging, including the 3T2 images, and also the diffusion weighted image. We start with the sagittal image, and we get the sagittal plan, and then we see where is the tumor located, and then we plan the axial image perpendicular to this tumor to allow precise evaluation of the circumferential resection margin and the extension beyond the muscle layer. Then we perform the coronal images, and the coronal images should be parallel to the anal canal. Why it should be parallel to the anal canal? Because we need to evaluate the relation of the rectal mass to the anal sphincter, because it is very important in the surgical plan, especially if the tumor is at the low rectum. This is the T2 weighted image, and we can see here that there is a tumor. This is the sagittal T2 weighted image, and after we perform the perpendicular axial image, we can see this nice axial T2 weighted image with the surrounding mesorectal fascia, which can be precisely evaluated surrounding the tumor. And when we perform the coronal images parallel to the anal canal, we can nicely see the anal sphincter complex and also the rectal lesion if present at the lower rectum. Diffusion weighted image allow identification of the tumor as a very area of hyper-intense signal on the diffusion weighted image, denoting its restriction, and this is an indirect sign of high cellularity of this tumor. Sometimes we get fallacies with the diffusion because of the mucinous tumors, because these tumors are very low cellular and they appear as no restriction on the diffusion weighted images. So diffusion will be helpful only if the tumor is not with high mucin content, and it is useful in initial staging and also in the restaging, which has a higher value of the diffusion weighted image. So what we should include in our report: the location of the tumor, the TNM stage, and the involvement of the mesorectal fascia. Let's start with the location of the tumor. As we mentioned earlier, the rectum is about 15 centimeters in length. It starts from the anorectal junction below and extends superiorly till the sacral promontory at the rectosigmoid junction. The rectum is divided into three major zones: the low rectum, mid rectum, and high rectum. The low rectum is extending from the anorectal junction to about 5 centimeters in length, and the mid rectum, when the low margin of the lesion is about 10 centimeters from the anorectal junction, and the high rectum is the upper 5 centimeters of the rectum. So it is 15 centimeters, every portion is 5 centimeters from the anorectal junction. The T staging, it depends on the assessment of the involvement of the muscle layer. T1 and T2 tumors are confined to the rectal wall with no extension beyond the muscularis propria. These two T1 and T2 stage are hardly to discriminate on MRI, and the proper staging for T1 and T2 could be performed by endoluminal ultrasound and not by MRI. But MRI, it is very important in staging of T3 tumors, because there is a tumoral extension beyond the muscularis propria. As we are going to see later, the extension of the tumor is discriminating T3 stage into 4 substages according to the depth of invasion of the tumor into the surrounding mesorectum. Into these 4 stages. And then lastly, T4 tumor, where the tumor is seen extending beyond the muscle layer, but not only that, but it is infiltrating the peritoneal surface, and it is staged as a T4A, or it invades any of the adjacent pelvic organs, including seminal vesicles, uterus, posterior vaginal wall, or the pelvic side wall, and it is staged as a T4B tumor. Let's see how can we assess the rectum. This is the T3 tumor, where the muscle layer is disrupted and there is extension beyond the muscle layer into the mesorectum. We can see here that the muscle layer appears as a low signal intensity, and it is of a smooth outline. When this low signal intensity line is disrupted, then this is infiltration of the muscularis propria muscle, and this transmits the tumor from T2 tumor into T3 tumor. And T4B tumor, when there is a true infiltration of one of the pelvic organs, as we can see here, there is infiltration of the seminal vesicles over here, and this is a T4B tumor. T4A tumor, when there is infiltration of the peritoneal reflection, we can see that the peritoneal reflection is crossing over here till the mid rectum, and then it is reflected again upward over here. We can see the peritoneal reflection here as this low signal intensity structure, and this is the huge rectal mass infiltrating the peritoneal reflection, and this can be staged as T4A tumor. And this is the axial oblique image performed perpendicular to this mass in this direction, and we can see that this is the infiltration of the peritoneal reflection. The peritoneal reflection in the axial images appear as a seagull appearance or the flying bird. This is the seagull appearance or the inverted V shape, and this is the infiltration of the peritoneal reflection in T4A tumors. What about the circumferential resection margin? Circumferential resection margin is actually a pathological term to identify the infiltration of the margins of the tumor after surgical excision, and it is evaluated on the pathological specimen as the minimal distance between the tumor and the surrounding mesorectal fascia. And this is a very powerful predictor for local recurrence rate. And if there is a violation of the circumferential resection margin, then the patient needs to have a preoperative neoadjuvant treatment to minimize the rate of recurrence. So if it is just a pathological term, why we are using it in our reports? Because it is very important. How can we assess this circumferential resection margin? We identify it as involved or non-involved, or negative margin or positive margin. Involved margin is when the tumor is less than 1 millimeter from the mesorectal fascia, or also when the tumor is seen in visibly infiltrating the mesorectal fascia. As we can see here, the tumor is completely infiltrating the mesorectal fascia, and this is a positive circumferential resection margin. Also, the tumor is violated if the perirectal lymph nodes is also violating the mesorectal fascia. So, if it is involved when the tumor or the lymph nodes is seen at a distance less than 1 millimeter from the mesorectal fascia. And it is not involved, or it is the negative circumferential resection margin if the tumor or the lymph nodes are seen completely separable from the mesorectal fascia with a distance more than 1 millimeter. We measure the maximum distance of the outward extension of the tumor to the adjacent mesorectal fascia, and this is the assessment of the circumferential resection margin. This is an example for how we can assess the circumferential resection margin. This is T1 and T2 tumors. They are completely separable from the mesorectal fascia because they are confined by the muscle layer into the rectal wall, and this is a negative margin. T3 tumors sometimes have a positive circumferential resection margin, and sometimes they could have negative circumferential resection margin. We measure the maximum extension to the mesorectal fascia, and as the tumor is broadly extending into the mesorectum, the margin will be more at risk to be violated, and we measure the narrowest distance to allow the assessment of the circumferential resection margin. So we classify T3 tumors as sometimes they are good T3 tumors and sometimes they are bad T3 tumors when the margin is very minimal or violated, and the good T3 tumors when there is a wide distance between the tumor and the mesorectal fascia, and these tumors are having a good prognosis than the other bad T3 tumors. T4 tumors, as we mentioned earlier, these are infiltrating of the surrounding pelvic organs, and this, of course, positive circumferential resection margin. Also, one of the important tools in the MRI is the evaluation of the anal sphincter complex. As we see here, there is a sizable low rectal tumor over here, and this is crossing the anorectal junction. This is the puborectalis muscle, and the tumor is seen extending caudally to infiltrate the internal anal sphincter. And the staging is depending on if it is only infiltrating the internal anal sphincter or extends to the intersphincteric space or also infiltrate the external anal sphincter. And the staging is classified according to its true extension. If it is just infiltrating the internal anal sphincter, it is staged as a T3 tumor, and if it is extending to the intersphincteric space and the external sphincter, and this is classified into T3B tumors. Also, one of the important items to be reported in the rectal cancer staging is the extramural vascular invasion, which is known as EMVI. This is the tumoral extension into the surrounding nearby vein around the rectum, and we can see here that the mass is seen protruding into the adjacent vascular structure within the mesorectum, and this is of bad prognosis because it allow for distant dissemination as the tumor is spreading to the adjacent vascular structure. As regards nodal staging, MRI is very helpful in nodal staging. So we can assess the lymph nodes usually at the level or above the level of the rectal mass. The lymph nodes are usually seen within the mesorectum, and we are classified the lymph nodes into two major groups. Either the lymph nodes within these are called the perirectal lymph nodes, and they are located at or above the level of the tumor. But important assessment of the lymph nodes outside the mesorectum, which are located within the obturator or internal iliac lymph nodes, is very important because it is outside the field of surgical intervention, and also it is outside the plan for radiotherapy lymph node assessment into regional lymph nodes with two groups, either perirectal lymph nodes or the extramesorectal lymph nodes located at the obturator or internal iliac groups. The lymph nodes, for staging of these lymph nodes to identify suspicious lymph nodes, we depend on three morphologic criteria. If we have an indistinct outline or speculated outline, if the lymph node is of heterogeneous appearance, and if the lymph node is rounded in appearance. Because the perirectal lymph nodes are usually small in size, if we have a size between less than 5 millimeter, we need at least 3 malignant morphologic characteristic to call this lymph node as a metastatic lymph node to avoid overstaging of these perirectal lymph nodes. But if we have lymph nodes of 5 to 9 millimeter, we need just 2 malignant lymph nodes. Recent publications discriminated that lymph node of more than 8 millimeter is highly suspicious for being metastatic lymph node, and it have a very high negative predictive value to avoid overstaging. 9 millimeter, and nowadays they are downstaged into just 8 millimeter. It is very suspicious lymph node to be called as a metastatic lymph node. Then we count the number of the lymph nodes either at the perirectum or the surrounding extramesorectal lymph nodes, and if we don't found any suspicious lymph node, then the stage should be N0 stage. If we have 1 to 3 lymph nodes, then it is N1 stage, and if we have more than 4 lymph nodes, then we are staging this nodal disease as N2 lymph nodes. Let's see what is the metastatic lymph nodes. When we see a lymph node in the rectal cancer, and this is not a regional lymph node, this is a metastatic lymph node. The common iliac lymph nodes, external iliac lymph nodes, inguinal lymph nodes, these are metastatic lymph nodes. The inguinal lymph nodes are metastatic unless we are dealing with a very low rectal tumor with secondary infiltration to the anal canal. Then these inguinal lymph nodes are not considered as a metastatic lymph node as M stage, but they are understaged into N stage group because the drainage of the anal canal is through the inguinal lymph nodes. But if we found common iliac lymph nodes or distant para-aortic lymph nodes, these are metastatic lymph nodes, and they are considered in the M stage, not in the N stage. So the regional lymph nodes are only at the mesorectum, at the superior rectal, inferior mesenteric group, or the internal and obturator lymph nodes only. Other lymph nodes are considered as distant metastatic lymph nodes or M stage. How we can assess treatment response after concurrent chemoradiotherapy by MRI. Treatment response, either complete response when there is no residual tumor can be visualized radiologically, and no response when there is no change in the pre-treatment MRI and the post-treatment MRI. Then we came to the dilemma for the partial assessment response. Partial assessment response is categorized when the tumor volume decreased by more than 50% of its volume, or there is downstaging of the tumor. If there is previously a violation of the circumferential resection margin, and then after treatment the margin became a negative margin, then this is considered as a partial response. Unlike other tumors, solid tumors, the treatment response should be decreased by 50%. In other solid tumors, by the RECIST criteria we use for evaluation of treatment response, we depend on 25 to 30% change in the tumor volume. But here in the rectum, we need at least 50% change to call the change as a partial response. How to assess the concurrent chemoradiotherapy response? We have two issues. We can use it as a qualitative assessment, and also we can perform quantitative assessment. The qualitative assessment, depending on the signal of the tumor on the T2, and also the enhancement criteria and the degree of diffusion restriction. And the quantitative assessment, which depends on the size and the volumetry of the tumor, and also by the measuring the ADC value, and sometimes we can perform the K-trans perfusion MRI for assessment of the vascularity of the residual lesion within the rectum. Let's see how this works. When the patient performed the concurrent chemoradiotherapy, they should delay the assessment of the treatment for about 6 to 8 weeks to allow the inflammatory process occurring after radiation therapy to subside and allow the rectal wall edema and swelling to subside, to help in discrimination of the post-treatment changes and the true residual viable tumor. So when we performed the assessment after 6 to 8 weeks, this is the initial MRI, and this is the post-treatment MRI after 6 to 8 weeks. We can notice over here that there is a significant low signal intensity noted at the left side of the rectum, which corresponds to the previously seen mass lesion on the initial MRI. This significant low signal denotes fibrosis, but is the T2 weighted image is enough to call that this is a fibrosis with complete radiological response? No, because sometimes within these fibroses there are hidden small malignant cells, and they are masked by the fibrosis on the T2 weighted image. So how can we assess this residual tumor? We are going to tell it just in a few seconds. Another way to assess the treatment response is by measuring the tumor, but because the rectal wall is flexible and not stable in all sequences, depending on the motility and the distension of the rectal lumen, the accurate measurements of the 3 orthogonal planes of the rectal mass is very difficult. So the tumor size by the conventional 3 orthogonal dimensions is less accurate than other solid tumors. And here comes the role of the MR volumetry, where we plot the ROI surrounding the mass to get the true volume of the mass before and after the concurrent chemoradiotherapy, and this is the most accurate method for assessment of treatment response as regards the volume of the tumor. But unfortunately, in spite of its high accuracy, it is very time consuming and it needs post-processing tools, which is not available in every day practice. So we can depend on the conventional T2 weighted image with the diffusion weighted image to increase the sensitivity of the T2 and also increase its specificity by the diffusion weighted image to discriminate between residual and complete radiological response. Here is an example of this huge rectal mass with central areas of necrosis, and this is the post-treatment change. The volume is remarkably reduced after treatment. So we are considering, is this a partial radiological response or this is a complete radiological response? When we performed the diffusion weighted image, there are no areas of restricted diffusion, and this is a complete radiological response, and this residual volume is just fibrosis as a post-treatment change, and it was confirmed on pathology. Let's see some cases. This is mid and upper rectal mass lesion located over here before treatment, and this is after treatment. The tumor shrinks down with an area of fibrosis noted at its posterior aspect. But when we are searching for residual tumor, we should assess the mucosal part, because this is the least portion to be responded and the last portion to respond to the therapy. Let's see the axial oblique images. This is the mass over here before treatment, and this is after treatment. We can see that after treatment, the tumor is showing a predominant low signal on the T2 weighted image, which is a good sign that there is a treatment response. But if this is a complete radiological response or just a partial response, we need the diffusion weighted image. This is the inverse image for the diffusion before treatment, and this is after treatment. There are few areas of restricted diffusion, and this indicates that this is a partial radiological response with small residual tumor located within the rectal mucosa over here, and this is a partial response. This is another example before concurrent chemoradiotherapy, and after concurrent chemoradiotherapy, the tumor size is regressed over here in the coronal and on the axial images as well. And this is the assessment on the diffusion weighted image before and after treatment. We can see that the tumor is very cellular and shows significant restriction on the diffusion weighted image, and there is still residual mucosal restriction over here and over here, and this is a partial radiological response. Another example for assessment of treatment response, this is the pre-therapy and this is the post-therapy. As we can notice over here, there is no no radiological response at all, because the tumor is stable in before and after treatment. And if the patient underwent previous surgery, we are aiming for assessing if there is any recurrence. We should search for the expected sites for recurrence. The mesorectal site is the most common site of recurrence of the rectal cancer, followed by the lateral pelvic side wall and the posterior pelvic side wall. These are the most common sites for recurrence if we are searching for a recurrent rectal lesion after surgery. The new MR modality included in the PET MRI is very helpful in staging and restaging of rectal cancer. PET MRI, it combines the high-end machines, including the state-of-the-art MRI for proper rectal staging, including the mesorectal involvement, and also for assessment of nodal disease, and it includes also the PET component for assessing distant metastatic lesions. The preparation for the PET MRI as the PET CT, it needs some fasting, and we perform the dedicated assessment for the rectal and the whole body assessment in initial staging and restaging, and also in assessment of recurrence. This is an example for a patient in initial staging by PET MRI. This is the sagittal T2 weighted image. We can see that there is a sizable mass extending outside the rectal wall into the presacral space, and this is proved to be completely a high FDG avid mass lesion. And this is the oblique images. We can see that the mass is seen extending anteriorly with the infiltration of the mesorectal fascia over here, and this is a positive circumferential resection margin. But also we can see that the mass is violating the anterior peritoneal reflection, and this is a T4A tumor. Also, we can assess that there are extra mesorectal lymph nodes located at the right hypogastric group, which is very avid on the corresponding fused images. And these are the true extension of the tumor outside the muscle layer within the mesorectum. And these are lymph nodes with violation of the mesorectal fascia, because there are no clear fat planes between the mesorectal lymph nodes and the mesorectal fascia over here. And this is again the positive circumferential resection margin. The nodal staging by PET component is increased compared to the conventional CT or MRI because of the additive metabolic data performed from the PET component. This is another example of another sizable rectal mass extending beyond the muscle layer into the mesorectum, which was proved to be very avid on the PET component. And these are the precise evaluation of the distant metastatic lymph nodes at the common iliac and the para-aortic groups, in spite that these lymph nodes are very small in size, and on the conventional images they are non-specific to be metastatic lymph nodes, but they are proved to be metastatic on the PET component. And this overstaged the patient to metastatic disease. For distant metastasis, it is very helpful also in staging for hepatic focal lesion metastasis combined by the MRI components, which is also demonstrated over here on the diffusion weighted image as multiple areas of restricted diffusion. And this is the map image demonstrating the exact heavy metastatic load within the liver. Another example for smaller metastatic affection in the liver, which could be missed on the conventional CT images if the patient was performing the routine CT for staging for hepatic focal lesions. This is another example of the additive role of the MRI component. This is a small lesion located subcapsularly over here with restricted diffusion, and it was proved to be metastatic lymph node and with increased FDG uptake on the PET component. In restaging, it is very helpful to discriminate the residual fibrosis from the true residual tumor. This is the pre-treatment PET component, and this is the post-treatment PET component, and this shows no FDG uptake, which indicates that this is a complete radiological response. And this was unfortunately misinterpreted as a partial response by the diffusion weighted image with areas of small restriction, but it was proved pathologically to be a complete radiological and pathological response after surgery. So sometimes diffusion can perform PET-FOL, but the combined diffusion and the PET component, this is better for restaging in rectal tumors, especially if the patient was refusing to perform surgery or will be under surveillance for his rectal mass. And also for assessment of recurrence, sometimes the routine conventional images become very bizarre, like over here, this is a recurrence or this is a post-operative granulations and fibrosis. This is very bizarre on the conventional CT or MRI images, but if we add the PET component over here, then we can discriminate, then this is not a granulation tissue, this is a true recurrence within the fibrosis located at the pelvis. And to sum up, the MRI in rectal cancer, it is very helpful in preoperative staging, especially to assess extrarectal spread for the extramesorectal lymph nodes or distant metastasis, and also for assessment of sphincteric involvement, if present, if there is a plan for sphincter sparing surgery. It is very helpful in assessment of treatment response after concurrent chemoradiotherapy, and also it is very helpful in assessment of local recurrence. Thank you.
شكرا جزيلا دكتورة رشا يعني for this very meticulous presentation. هل فيه لسه رول للترانسريكتال التراساوند في ال assessment of rectal carcinoma?
In early stages, T1 or T2 tumors, if the patient will undergo local excision for the tumor, then transrectal ultrasound is very helpful in assessing T1 or T2 stage. But in higher stages, MRI is superior than transrectal ultrasound.
الديفيوجن في الام ار في الاول خالص دكتوره رشا، هل ليه added value يعني في الكيسز حضرتك ما كانش فيه؟
الديفيوجن is very helpful لما بنحطه في الانيشال staging، بيبقى helpful لما بنيجي نتابع بعد كده هل الديجري بتاعت الريستريكشن ما زالت لسه موجوده، لان الديفيوجن هو بيعتمد على الجريدينتس وبيبقى susceptible لارتفاكتس كتيره، اهمهم الاير انسايد ذا ريكتال وول والموتيليتي بتعمل ارتفاكت. فمشكله الديفيوجن ان هو بيبقى susceptible for artifacts اكتر من اي سيكونس تاني في الام ار اي. فلما بنحطه في الانيشال ستيجنج بيبقى very helpful لما بنيجي نعمل بعد كده assessment للكونكرنت كيموراديوثيرابي، بيدينا يعني good predictive value ان ده فعلا responder ولا non responder. لكن مشكلته زي ما قلت ان هو في الحالات بتاعه الميوسينس تيومرز او التيومرز اللي بتبقى على tubulovelous adenomas بيبقى unfortunately مش helpful، لان هو بيبقوا very low cellular tumors وما بيبقوش باينين في الديفيوجن. فهو مش هيبقى helpful في الميوسينس تيومرز او التيومرز اللي هي on top of tubulovelous adenomas.
طيب البيت سي تي والبيت ام ار which is better؟
البيت ام ار هيبقى better عن البيت سي تي for local staging. الديستانت ستيجنج سواء للنودال او للهيباتيك ميتاستاسيس هيبقوا ذا سيم تقريبا، لكن بالنسبه لللوكال البات سي تي ما يقدرش يعمل لوكال ستيجنج بروبرلي للريكتال تيومر، لانه نفس الحاجات اللي هو بتاعه السي تي كومبوننت هو مش هيقدر تو اساس الميزوريكتال فاشيا، مش هيقدر تو اساس الماسل انفيجن، هو جاست هيبقى هيلبفul في الاسسمنت للليمف نودز سواء كانت ميزوريكتال او اكسترا ميزوريكتال، وهيبقى هيلبفul للديستانت نودال والهيباتيك او لونج ميتاستاسيس او الكلام ده. فلو انا عايزه اعمل وان ستوب شوب واعمل وان اكزام واجيب بيها كل الداتا، اي جاس ان الام ار بيت كومبوننت هو ده اللي هيبقى ذا بيست افيلبل تول يعني.
even initial assessment not
في كل حاجه، الانيشال والبوست تريتمنت وبعد لو في سسبيشس للريكورنس، لان ساعات ان بعد الجرانيوليشنز بعد السيرجري لو كنا والتايمنج بتاعنا مش مظبوط، فالكومبينيشن بتاعه البات بتبقى فيه ابتيك في الجرانيوليشنز ديت، فلو احنا التايمنج مش مظبوطه قوي في الاسسمنت فممكن يبقى عندي فولس بوزيتيف ريزلتس يطلع لي في البات كومبوننت. لكن لما بحط الام ار اي بكل التولز بتاعته مع البات كومبوننت، الكومبينيشن دول مع بعض، يعني انا جبت اعلى 2 ايميجنج موداليتيز افيلبل، فبتبقى الاكيورسي بتاعتها هتبقى اعلى كتير من ان انا اعتمد على 1 ايميجنج موداليتي لوحدها.
دكتور هاني
طيب ممكن
اتفضلي. اتفضلي يا دكتوره
رشا. ازيك يا رشا؟
ازي حضرتك عامله ايه؟
ما بتحقنيش جل خالص؟
لا الجل هو في الجايد لاينز دلوقتي، هو كان زمان بصراحه يعني في حالات انا كنت حطاها كنا حقنين جل، دي حالات قديمه شويه، دي كانت في الانيشيال. دلوقتي الجايد لاينز they don't recommend ان احنا نحقن جل علشان ده بيدي false impression للفايوليشن للcircumferential resection margin. فلو انا عندي، لان ده بيعمل ديستنشن للريكتم فبيقرب لي الريكتم من الريكتال وول من الميزوريكتال فاشيا، فممكن يديني لو التيومر طالع كتير بره الريكتم هيديني فولس بوزيتيف ان في فايوليشن للريسكشن مارجن. فاتس بيتر ان انا ما استخدمش الجل خالص unless ان انا عندي بايز ان انا I can't identify الليجن، ممكن احقن minor amount من الجل، ما اعملش full distension للريكتم، بقى بحقن كميه بسيطه جدا يعني just one syringe اللي هي بتبقى ال 60 ديت، ويعني بنخليها limited لما ما نكونش عارفين نشوف. ومع القرايات الكتير خلاص بقينا بنعرف ان احنا نجيب اللوكيشن اكزاكتلي من غير الريكتال جل تماما. احنا مشكلتنا كلها بتبقى في البوست تريتمنت اسسمنت، لان ده الريكتم كله بيبقى ثيكند وادامتس نتيجه الراديوثيرابي، بيبقى عامل سيفير بروكتايتس، ولو العيان ده كمان ريسبوندينج فالماس بيبقى فانيشنج ماس تقريبا. فلو ما عندناش انيشيال ام ار اي هي دي اللي بتبقى المشكله شويه في الاسسمنت للبوست تريتمنت ريسبونس يعني. لكن initially غالبا ما بيبقاش فيه مشكله لان معظم البيشنتس جايين بفيري هيوج ماسز يعني.
طب لو بتعملي اسسمنت للانال سفنكتر بتاخدي لها كاتس ثانيه بقى، لانك انت بتاخدي السلايس ثيكنس بتاعتك متهيألي مش 3 مللي، هل بتاخدي سيكونسز مخصوصه للانال سفنكتر لو انت شايفاها له ريكتال؟
لو له باخد ديديكيتد على الانال كانال سيميلر للبيري انال فيستيلا علشان تؤسس فعلا في تريتمنت في انفلتريشن للانترنال سفنكتر ولا دخل على الانتر سفنكتريك سبيس ولا كمان فايوليتد الاكسترنال سفنكتر، لان ده بيفرق جدا في السيرجيكال بلان ان هو هيعمل انتر سفنكتريك ريسكشن ولا هيبقى ابدومينو بيرينيال، فده هتفرق كتير ساعات في بعض البيشنتس يعني.
انا بس
لو يونج يعني.
انا بس ريكومند فور يو ان انت لو هتعملي كده خدي الكاتس بتاعت الانال سفنكتر وانت بعد الصبغه على طول، لان هي بتبان كويس قوي، والانترنال سفنكتر بتبقى انهانسنج.
ده حقيقي ده حقيقي. الانترنال سفنكتر
يعني لو هو لو ابتدي بالانال سفنكتر.
تمام.
دكتورة هاني لحضرتك أي تعليق؟
أنا بشكر طبعا الدكتورة هالة، غطت معظم الأسئلة وكل الكلام اللي الجراح يحب يعرفه. طبعا احنا الام ار اي بيزد ستيجنج ده هو اساس البري اوبراتيف بلاننج بتاع المانجمنت بتاع الكانسر ميد ولو ريكتم، مفيش شك يعني بنعتمد تماما. ففعلا كل الانفورميشن المشكله ان في بعض الراديولوجيست ما بيبقوش اورينتد بالكلام اللي قالته الدكتوره رشا، وبعتوا لنا تقارير ما بتفيدناش. يعني لازم التقرير يغطي كل اللي قالته الدكتوره رشا بالظبط، يعني بالنسبه للتي ستيجنج، بالنسبه للسيركمفرنشال ريسكشن مارجن، بالنسبه للليمف نود ستيتس، بالنسبه للليمفوفاسكولار انفيجن، بالنسبه قد ايه من الميزوريكتم متاخد. يعني ده مهم جدا، ففي كتير قوي ما بنلاقيش في التقرير الحاجات دي. انا ليا بس تعليق وسؤال. التعليق بالنسبه للالترا لو ريكتال كانسر، فطبعا حضرتك غطيتيه تماما، انما هو في تقسيمه جراحيه يعملها ريليو الفرنساوي اللي هو السوبراسفنكتيريك والجاكستا والانترسفنكتيريك والترانسفنكتيريك. فدي برضو لو دكتور الاشعه بيبقى اورينتد بيها هيساعد في انه الستيجنج يعني يذكرها في التقرير بتاعه ان هي السوبراسفنكتيريك في الالترا رو يعني اكتر من 1 سم من السفنكتر من انوريكتال رينج، عشان دي خلاص بتتعامل توتال ميزوريكتال اكسجن زي بقيه الكانسر ريكتم. لو اقل من 1 سم بنسميها الاولانيه سوبرا، دي جاكستا سفنكتريك، معناها اقل من 1 سم من الانوريكتال رينج او السفنكتر، فده بيتعمل له partial intersphincteric resection preserving يعني preserving بقيه الاسفنكتر. لو واخد الانترنال سفنكتر يبقى انترسفنكتريك، ده بيتعمل له ممكن يتعمل له توتال انتر سفنكتريك ديسكشن. انما لو واخد بقى الاكسترنال سفنكتر ده بنسميه ترانس سفنكتريك، وده بيبقى عايز ابدومينال برينيال ريسكشن، مفيش بقى سفنكتر بريزيرفنج في حاله زي كده. فده تعليق يعني، لو برضو بيبقى الاشعه اورينتد بالتقسيمه دي هيكتبها في التقرير بتاعه وهو شايف قد ايه التيوب. السؤال بتاعي بقى، احنا بيجي لنا عيانين يعني ادفانسد، وبنفتح العيان نلاقي عشان نعمل حتى بالياتيف ريسكشن ما نعرفش، لان بنلاقي فروزن بيلفس وبريتونيال نوديولز اول اوفر ذا بريتونيوم وشويه مينيمال اسايتس كده حتى انما هل في موداليتي تشخص لي الحاجات دي عشان ما افتحش العيان اصلا؟ انا افتحه واقفله، هذا خلاص ميتاستاتيك بريتونيال نوديولز اللي هو كارسينوماتوزس بريتونيال اول اوفر ذا بريتونيال كافيتي، او حتى في بعض الحالات لو حاجه بسيطه ممكن يتعمل ابقى مجهز له هايبك مع يعني في موداليتي
هو زي ما
حضرتك الحكايه دي.
هو البيست ايميجينج تول للبريتونيوم هو الديفيوجن ويتد ايمج في الام ار اي. ده بيأسس along البريتونيال ريفلكشنز اول اوفر، يعني الباري هيباتيك ساعات بتبقى باينه جدا في الديفيوجن عند الباراكوليك جاترز اللي هي الحتت الهيدن كمان من البريتونيال ريفلكشنز بتبقى باينه بالديفيوجن ويتد ايمج. فده بيبقى very helpful tool، ده احسن imaging tool للبريتونيال ديزيز هو الديفيوجن.
بس يعني هل ده بيبين؟ طب ما هو ما بيبين لناش، هو بيجي يقول في اكستنسيف تيومر واخد كذا وكذا وكذا، بس مش قايل ان في بريتونيال، ما بيشوفهاش. يعني في حاجه تشوفها اللي هي سكاتر دي اول اوفر ذا بريتونيوم، ودي
ايوه ما بتتشافش. هو ده يعني لو هو حضرتك الديبندز على الاكزام اللي معمول، لو هو معمول على الريكتم فقط فهو هيعمل جاست الجزء بتاع البلفس. لو هو مطلوب ابدومين وبلفس هيشوف الديسيمينيشن اول اوفر البريتونيوم في الاومنتم والبريتونيال جاترز والكلام ده كل ده هيبان لو معمول له كمان ابدومينال كومبوننت. لكن اتليست من البلفس
ده هيبان بالام ار اي بس ولا لازم بات ام ار اي؟
لا ده ممكن بالام ار اي لوحده
يبان بريتونيال كارسينوماتوز.
البات كومبوننت في الحته دي بيبقى ويك. الام ار اي هو اللي هيبقى اعلى في الدايجنوسيس. الويك بوينت بتاعت البات هي البريتونيال ديزيز، لان بيبقى الباول جنبيها فيها ابتيك فبتبقى الدنيا ماسكت مع بعضها. لكن الام ار اي بنقدر نشوف البريتونيال ديزيز فيري ايزي، بيبقى بالديفيوجن بنشوف.
اوكي شكرا دكتور رشا.
العفو يا دكتور.
شكرا جزيلا دكتوره رشا، شكرا جزيلا استاذنا دكتور هاني بيه، شكرا جزيلا دكتوره رانيا. ان شاء الله يعني نلتقي بحضراتكم في سيشنز اخرى. شكرا جزيلا لكل الزملاء اللي بيتابعونا. ان شاء الله نلتقي يوم السبت اللي جاي ان شاء الله في سيشن فيلم ريدنج لاستاذنا الدكتور احمد فريد بمساعده دكتور محمد حافظ ودكتوره هند عبد الله، احد الناس الشطار جدا من عندنا من بنها، يعني بنتنا يعني. نلتقي ان شاء الله يوم السبت القادم ان شاء الله. شكرا لكم جميعا. السلام عليكم ورحمه الله وبركاته.
وعليكم السلام. شكرا للجميع.